Good morning, everybody, and welcome to the Health and Adult Social Care Scrutiny panel.
To ask questions to either Cathy or Stuart as well. So in terms of the actions, we clarified the information pathway for children with ADHD. What we've now done is combined that into what we call a neurodevelopmental pathway. So that's looking for any kind of neurodevelopmental differences. And the lead clinician for that is very much cited on the NICE guidance, and are currently making links with the paediatricians within Calderdown Huddersfield Foundation Trust and within Mid Yorks. So basically, it's still as it was last time. There isn't any specific support within that neurodevelopmental pathway for children and young people with fetal alcohol spectrum disorder. But if the child had an associated learning disability, it'd get picked up through that pathway, and as would behavioural issues. The other thing that we've done, which we're quite excited about, is the Department of Health have released a funding round for awareness raising for fetal alcohol spectrum disorder, and we're currently in the process of supporting Locala to put a bid in around that process. I don't know when the closing date is, Stuart, for that.
I think it's the end of next month.
Yeah, so that's fairly imminent. So that's really the summary of the actions we took following the last board. So happy to take any questions on the detail of the report and progress.
Thank you for that. Would you like to ask questions?
Thanks. Yeah, two questions. The first one just on incidents. Sorry. It's flashing green, by the way.
Yeah.
Great, good. I'll start again. Yeah, first question's on the issue of incidents. In the main report on, in the background paragraph, first paragraph, there's reference there to results have shown 5 cases, an average of 1 per year, so very low incidence. And in the report issued by NoFast UK, at the top of page 5, there's a reference there to a suggestion that a minimum of 3.96 million people in the UK could be affected by FASD. So I found it difficult to kind of put those two things together. So that's the first question. I've got another one afterwards. Yeah, thanks.
Yeah, thank you. So in terms of the data, sorry for not being clear about that, the initial data that we got from the hospital trusts is in relation to fecal alcohol syndrome, because that's the only thing they record. So the fetal alcohol spectrum disorder, we don't have any data on that locally. So I would take those national estimations and extrapolate them down to Kirklees are probably correct.
Okay, yeah, the second question's about the section on prevention. So that's paragraph 4, page 15 of our set. And it was an aspect of prevention which relates to the way in which alcohol use is promoted. And there's a very interesting that first paragraph there, which says fetal alcohol syndrome is completely avoidable if alcohol is not consumed during pregnancy. So it seems that it's really important to get that message across. Now, in The Guardian yesterday, there was a report by Professor Mark Pettigrew of the London School of Hygiene.
Trimester, which is basically trying to get people to not drink at all during pregnancy. I mean, the guidelines now are very clear in terms of no alcohol equals no risk. We are at the moment, as mentioned in the report, as part of the local maternity system work, we have an expert group around substance misuse, which includes alcohol. And that group will be coming up with recommendations around activity at place and at scale. My expectation, although I can't predict, but my expectation would be that one of the recommendations in terms of the at-scale work around that would be some kind of campaign or awareness-raising activity. Those groups have a lifespan of a maximum of 12 months, so the recommendations will be coming out of that sooner than that, one would hope, and coming back to kind of place as well. So at the moment, the activity in terms of promotion and raising awareness is done primarily on a one-to-one basis between the midwife and the woman that she's seeing, she or he is seeing, or the 0 to 19 practitioner with their kind of antenatal contact. So they are given kind of resources either on a paper basis or directed to electronic kind of online ones via their notes now. But yeah, there is a gap in terms of a kind of a national or a regional campaign, but it is something that we're looking at from the local maternity system.
So is the group that you mentioned that's looking at this issue, would they be likely to take note of this report that was in the reference in The Guardian yesterday?
They should be aware of that, and I will flag it with them after today's session. They're aware that I'm coming to this meeting today, so I can feed that back.
Sorry, could I just ask the question? It's very close to the one my colleague just asked, but I note that at the time of women booking into the maternity service, midwives ask women about their alcohol. Well, can I just ask at what point, how many weeks pregnant are they when they booked into that service? Because it seems to me that you really need to, this needs to be almost before they get pregnant. So how are you going to deal with that problem?
That's a very valid point, and it's relevant to a number of different health behaviours. You could kind of make the same argument in terms of smoking during pregnancy as well. So we're very, it's definitely an issue, and for most women, they would be booking in with their midwife, say kind of about 10 weeks. They have to be seen before 13 weeks. So from that perspective, it's quite late in that pregnancy journey. That's why within Kirklees, and again within the work of the local maternity system, but we've been working on it in Kirklees for longer than that, we do have a focus on work around preconception. So the whole concept of actually being healthy and fit before you actually get pregnant. So trying to work through people like primary care and sexual health services, but it is at the very early stages. We've done some initial scoping and trying to understand what the knowledge and awareness is out there within the community, and we're now trying to use some of the national resources that have been developed to actually kind of implement something locally.
Thank you. Just following on from that, so would a woman, what happened to me was I obviously went to see my doctor first of all, who then referred me. So presumably they still go and see their doctors first of all. Is that could something be done then at an earlier stage? That's what I'm trying to get at. Yeah.
They are trying to change the system so that actually that first contact is directly with maternity systems rather than having to go through a GP to then see the midwife. But they would still, because of needing to assure that the pregnancy is, kind of confirmed, the maternity system services don't kind of want to see them too early in that thing. So that's where the element around the kind of the preconception support. So what we're trying to do is to work, like I say, with primary care, sexual health services, other kind of community points, I suppose, where women and their partners are in contact with services, and more generally to actually kind of raise awareness of the factors that will make a difference. So there are some really good national resources that have been developed by Public Health England and Tommy's, so the national charity Tommy's, that would actually support people in kind of gaining knowledge and if they are actively planning a pregnancy. But obviously there are a large number of pregnancies that aren't planned. So there are then links back into kind of the education system and some of the work that's going on around the new RSE curriculum, so the relationships and sex education curriculum, and trying to embed some of that kind of thing in there. But it's preconception as a concept is huge, and it can kind of go full circle and look at before any pregnancy, subsequent pregnancies, all that kind of stuff. So it's trying to identify all those touch points and ensure that we've got that kind of consistency in information. And all the work, I know I keep saying about the local maternity system, but all the work of the LMS has a focus on preconception as well as kind of the antenatal, intrapartum and postnatal period. So it is a key part of the work that we're looking at now.
Hi. So you spoke about the neurodevelopment pathway. Until we obviously get some guidance from NICE in terms of what we're doing, what do we have in the interim to kind of support those people who are showing signs of this, and how is that recognised by our staff, medical people? Because without any clarification as to what it is, how can we ensure that we're giving them the best support that we can? Thank you.
Yeah, I mean, in terms of the neurodevelopmental pathway, it's all it's quite interesting actually, because what they've done is opened up the referral pathway to self-referral and schools. So what you'll get now is a full, obviously in line with paediatricians, you'll get a full developmental history children. The interesting thing is that, as I said earlier, fecal alcohol spectrum disorder presents, my understanding of it is it presents very much like autism or ADHD, so those services are already in place. So if a child's displaying any kind of behavioural difficulties or neurodevelopmental difficulties, that will get picked up by our current pathway. Now, I think what the interesting bit is how the NICE guidance is going to discern the difference, because I think, being frank, when both myself and Stuart have done the research and looked, I really can't find a great amount of difference between fetal alcohol spectrum disorder and autism. So I think we're going to have to be very, very careful about how we unpick that. But in the meantime, what we've done is we've put a parental support worker in who works alongside the neurodevelopmental pathway. So we're piloting that for a year to make sure that there's support around the behavioural issues. And the other thing is, through that pathway, they get access to the whole child and adolescent mental health system. So we have crisis provision, we have home treatment provision. So there's quite a wide offer. It's just that at that point, we wouldn't be calling it fetal alcohol spectrum disorder, but we are making sure the lead clinician, Helen, is linking in with the paediatricians to try and kind of ascertain what more we can do in that arena, really.
I guess until we get some more guidance, and it's also, even after we do get these guidance, where do you kind of, in which box do they really, sorry, it sounds really red, but you know, which box do they really sit in? Because if it is just so close to autism, and obviously that is the treatment that's needed, and yeah, I get that, thank you.
And I completely agree, and I think one of the challenges we face as a system is how many different, to use your terminology, how many different boxes do we put children in, and is there value in that? So there's always been an ongoing debate in relation to autism about do you know, is the diagnosis a useful thing, or is it more about how we support families, and you know, so there will be an ongoing debate about that, you're right.
I mean, would I be right in thinking that this is it's a very interesting intellectual debate, and everybody's doing their utmost. I mean, I looked at the standards for midwifery training, and midwives are absolutely tutored about this from very, very early on. Paediatricians presumably know about it. And, you know, is it not a bit of an academic enterprise? Because at the end of the day, I think what you're telling us, Tom, is that there are services already in place to which these children would fit. It just so happens that, that it's intellectually satisfying to find out this is what has caused it, or this is what we think has caused it. I suppose what I'm endorsing is what you've said. We seem to have in place what is needed, but we don't have it for that label. So in a sense, it's a bit of an artifact, and very important. Don't undermine its importance. But so we're right in thinking with regards to provision, it's there. Yeah. And we're right in thinking about midwives, that they're not missing this, because a good many of these women, as we know, if you've ever met them, are not terribly truthful about this. Thank you.
I mean, I think it's fair to say that from the original deputations from the parents who came, I think they felt that paediatricians didn't have a good, if I'm being fair to the original deputations, they'd say paediatricians didn't have a good understanding of fetal alcohol spectrum disorder. And I think part of what we need to do and why we've put the bid in is to kind of raise awareness around that particular aspect of it. But yeah, I think we're satisfied that in terms of the services that we've got, it would pick up those symptoms and make sure families had support. But what will be interesting, and I think is what the regional group's waiting for, it's what we're all waiting for, is what this NICE guidance is going to say. Because that will be, you know, and maybe there's some evidence that will say there are different symptoms, or, you know, we just don't know yet. But until then, I think we're quite satisfied that we can meet that need.
Yes, thank you. I've got another question on the crisis of commissioning report, the NOFAS report. It's on the recommendations. As I understand it, the report was issued in May, I think. Just wonder whether there's any initial response from the Department of Health or elsewhere on the recommendations, particularly the third and fourth ones, which relate to the CCGs. One's about training, one's about the need to commission and have a champion within CCGs.
Yeah, I mean, I think in terms of that crisis for commissioning report and the recommendations, the CCG haven't formally responded to those yet. I mean, particularly because it's guidance at the moment, and I think what's going to happen is they're going to get included in the NICE guidance. But in terms of the CCG being focused on it and cited on it, obviously we cited on it through scrutiny, and we're trying to do what we can around it. So there hasn't been any formal response to that crisis of commissioning at the moment. And I guess for, you know, if we were identifying a champion at the moment, that champion would be Stuart in terms of the child and adolescent mental health system, but we'd also have Cathy within the maternity system as well. But without being disrespectful to the report, it's quite difficult to champion something that we're not clear about the difference between other conditions.
I'd like to ask you, in terms of on page 16, you've identified that you'll be looking at increasing the knowledge of professionals. Now, is there a programme that you've already put together for this training? Do you have any training that's already in the pipeline?
The answer is that's in development, so we haven't decided just what form that's going to take yet. And as Tom mentioned, there is a funding bid that we're preparing through Locala to the Department of Health, which will give us some resource to address these issues. And part of that will include sharing of information with other areas of what's the best way to go about this increasing of knowledge.
Yeah, as Stuart's saying, I think, you know, part of when the bid, you know, I mean, I'm quite happy to circulate the bid once it's been submitted to board members as well, so you can see what the detail is.
Considering that this work is already sort of ongoing and the research is ongoing, do you not think that it's sort of imminent, rather than, you know, you're still working on a funding application and, you know, the bid's going to be submitted? What sort of timescale are we looking at?
Do you mean in terms of when the bid will be submitted or when the work programme will start? Yeah. Yeah. The bid's got to be submitted by the end of next month, so we'll get that in fairly soon. It's difficult to say until the NICE guidance is published really just what the training will need to focus on, so hopefully we'll start to see some draft copies of that or some feedback from the consultation that will help to guide us on what the content needs to be.
Okay, but as part of like your own assessments, your own staff sort of development plans, have you not picked anything up that you need to focus on there? Any skills that you need to, you know, work on?
I think obviously it's not about the staff that we employ, it's about the people that we commission to deliver the services. And what Stuart's done is talk to the clinical lead in the neurodevelopmental pathway to look at what the differences in training requirements would be between the paediatricians and the neuro pathway, to see if there is anything different. So we're not doing anything waiting for the bid. But I think, as I said, part of the problem is still trying to ascertain what's the difference between fetal alcohol spectrum disorder and what's the difference between autism and ADHD. And I think at the moment, the most we can do is look at awareness raising, and that's the approach we're taking until we're clear what the NICE guidance is delivering. So we are raising awareness throughout the services. It's just the specifics are very difficult to nail down at the moment.
Just one more. Has there been any awareness raising within communities on this issue?
No, not as far as I'm aware. I mean, we've got the prevention agenda, which Kathy's touched on, which, you know, the message is that no alcohol in pregnancy is the safest route. I think people are generally maybe more aware of fetal alcohol disorder, not the fetal alcohol spectrum disorder. But again, we can look at how we can tie awareness raising in particular communities into the bid.
Because in my opinion, that's where the root cause is. So if we're not reaching the communities and we're not raising the awareness within the communities, we're not really dealing with the issue.
I mean, I think it linked. There are so many other kind of issues as well that run alongside it that I think it's about tackling, to my mind anyway, a range of the issues that have an impact on women's health during kind of pregnancy and then the kind of the maternal outcomes and the infant outcomes. So I think it's trying to kind of package them up rather than going to communities and kind of about a number of different things. So the preconception kind of umbrella term is one way for us to look at doing that, I think, rather than going in with, well, this is what we need to do about alcohol one week, and this is what needs to happen about smoking another week, that kind of thing. So trying to tie it all together, so ensuring that those services that are working directly with communities, peer supporters, those kinds of things, have got that level of knowledge and understanding about the things that will make a difference in terms of someone's likelihood to actually get pregnant in the first place, as well as having a healthy pregnancy and then a healthy infant that's then going to develop healthily through their childhood. So to my mind, it's trying to package them all up together rather than being kind of single issue focused. And that's what we're trying to look at.
Yeah, that I was going to ask you about that actually, Kathy, was do you have any sense of, because we've been given quite low figures for the diagnosis of FASD, and I wondered if you have any sense of how that compares with the effect of tobacco or other drugs. What rate of damaged infants do you think come through from other behaviours?
I mean, because it's not something, alcohol consumption during pregnancy isn't something that's formally reported on within any of the kind of maternity dashboards and that kind of thing, although they do record it because it's a question that they ask. So maternity services have been able to provide me with some information, but I've only got it from one of the trusts at the moment. But they've told me that from the 2018-19 year, so this is for the whole of the Mid-Yorks footprint, so Wakefield as well as North Kirklees, they had 7,500 births. Out of those, at the booking questions where women are asked what they were drinking, 49 women said that they drank 1 unit a week, and 8 said that they drank more than 6 units. Obviously, that's self-reported, and we can kind of temper it with that disclaimer, I suppose. But in terms of smoking, for example, as a direct comparison, it's a lot. Although, again, it's self-reported, it is also backed up with CO monitoring. So there is a way to actually test that. If somebody says that they're not a smoker, they can be asked to blow in the little gadget that would monitor, and register kind of how their CO levels were within their body. And our smoking rates, not wanting to give you another issue to look at, but there you go. There are. That's an ongoing problem that's still a significant issue, I would argue. So in terms of, when you talk to maternity colleagues, it's not something that they are kind of saying that they're seeing lots of problems with. We do have the alcohol treatment services in place. We have 2 specialist midwives, 1 in each trust, who do direct work with women. But those women tend to be the ones who are already engaged with treatment services. So it tends to be the people who already have an acknowledged and identified alcohol kind of problem. And then the services are kind of already in place and wrapped around those women, and they just layer in that additional kind of midwifery support. It seems to me from the conversations we've had that it's quite a rare occurrence that somebody will kind of pop up at a maternity booking appointment reporting to be a very heavy drinker that's not already engaged with services. So the workers, from what I understand it, within the alcohol treatment services and midwifery services do work very closely together.
In terms of the midwifery support, the referral process to Swans, and that's only in Huddersfield for patients over that way. Do you have something similar for the north side?
Swans covers the whole of Kirklees, but is geographically located currently just in Huddersfield. So we do get women from North Kirklees going there. The specialist midwife from Mid Yorkshire Trust will go with women to that to those sessions, but it's obviously not ideal. Actually, as part of this process of doing the work for this paper and also some issues that have been raised at one of our Maternity Voices partnerships, there are conversations now going on around actually the what can we do in North Kirklees around that kind of client group. But it's literally at the very early stages. I've seen an email in my inbox this morning about it, but I've not had a chance to read it yet. So it's acknowledged that it's a potential gap, but women from North Kirklees are accessing the Huddersfield site. So at the moment, it seems to be being managed in that way.
A possibility of something coming in the north is something that you could might come up really.
Yeah, it's something that we're definitely looking at. Yeah.
Thank you for that. Is there any further questions? Okay. If there's no further questions, I'd like to recommend that once the bid is completed, that the panel members have sight of that to see what sort of things that you're requesting, and we note that the report and the information that's in it. Thank you. We're now going to take a short break and we'll resume shortly. Good morning, and thank you for joining us at the Health and Adult Social Care Scrutiny panel. We're going to be moving on to the agenda item of planning for winter across the social care system within Kirklees. In terms of the report, I'd like you to introduce yourselves and introduce the report. And once you've gone through the main report, we're going to move straight into questions, if that's okay with yourselves. Okay? Okay.
So good morning, colleagues. Can I introduce the team that have come to represent the Kirklees Place-Based System report for winter delivery? So I'm Helen Seven, Service Director for Integrated Commissioning.
Jane Close, Chief Operating Officer Lacala.
Amanda Evans, Service Director for Adult Social Care.
Andrew Singleton, Emergency Preparedness Resilience Response Manager from North Kirklees CCG and Wakefield CCG.
Good morning, I'm Sharon Wallace. I'm the Head of Emergency Preparedness Resilience and Response for Wakefield and North Kirklees CCG. Can you put your mic in first? Do you want me to repeat that? Yes, please. Good morning, everybody. My name's Sharon Wallace. I'm the Head of Emergency Preparedness Resilience and Response for Wakefield and North Kirklees CCG.
Morning, I'm John Parnaby. I'm the Transformation Programme Manager for Urgent Emergency Care, working across Greater Huddersfield CCG and Calderdale CCG.
Hello, good morning. I'm John Keaveney. I'm from South West Yorkshire Partnership Trust. I'm Deputy Director for Services.
So we're here today, as the introduction said, to update Scrutiny panel on the preparedness for winter resilience across the Kirklees Place-Based System. I think colleagues will be already aware that winter pressures in Kirklees is managed through the two A&E. One's a delivery board, one's a delivery group, one which covers the Mid-Yorkshire Hospital footprint and one which covers the Calderdale and Huddersfield Trust footprint. In the paper today, you've got the key summary of examples of what will be done during the winter for 1920 based on the experiences and evaluation of the reports from the both 17-18 and 18-19 winter plans. So I'll let colleagues take through those reports when you're probably asking the detail of the questions that I'm sure you've got ready for us today. And can I just bring your attention to Appendix 6 in the background papers. In the paper on page 27, it does say the Kirklees Council Winter Plan. That's my mistake, I apologise. It's actually an extract from the Adult Social Care Winter Plan, which you've got in your papers. Also to say that the appendices are at a moment in time. Some plans have been agreed internally through governance processes within the organisations as part of the system. So, for example, Calderdale and Huddersfield Foundation Trust report is actually an agreed report, as is the Locala plan. That's been through the governance and the board at Locala. The other plans are at a stage in time and have still, in some cases, got to go through the agreed governance process within their own organisations. But the reports will be summarised for both systems at both A&E, Group and Delivery Board, I think sometime in November. And colleagues can update you on those timescales. And then if you want to receive the final versions, we can make sure that you've got copies of them. So hand over to questions.
Peter, do you want to kick off?
Can I thank everybody for the level of detail that you've given us? I think the problem wasn't reading it; it was actually picking it up off the doormat, and the inguinal hernia subsequent to it. I wanted to begin, and this is not a criticism, but there are 3 bricks missing from the wall. We don't really know about GP preparedness. We don't really know about the state of population immunisation, and we know that you're doing all you can for staff, and we don't know about the Yorkshire Ambulance Service. And I ask what I ask really in the light of 2 things. One only came out this morning, so I wouldn't expect you to have an answer, and that's the CQC annual State of the Nation report, which does have a lot to say about acute services and social care, and talks about the whole system being under pressure, which is no surprise. Sorry?
No, I just said that. Sorry, I didn't mean to interrupt. I just meant that's an understatement.
And secondly, to look at these questions inter alia with the BMA's appraisal of performance last year, which is called a hidden crisis. And taking those two together, as I said, not meaning to be destructive. My first question was really about this CQC called their report a perfect storm, which we know this is a cliche, but it's a meteorological term, you know, where you get this constellation of circumstances that drastically aggravate the outcome. You know, they sink your ship. And in looking at the worst case scenario, I just wondered who's really in charge of all of this. Is this just NHS England? Or how much local control is there to coordinate? Because you've all got to work together in one way or another, and that comes through very well that you talk to one another, and that's impressive. So who's in charge? Florence Nightingale would have asked it.
So if I make a start and then I'll bring colleagues in who are part of the system development of the plans. Just to answer your first question, in relation to the GPs and the GP preparedness, in both system plans for Mid Yorkshire and CHFT, there is reference towards the development of extended access and extended hours opening of GPs, and that's already started now. But we can highlight that specific section with you. I understand also that Yorkshire Ambulance Service is a part of both system plans, and they very definitely sit on both A&E boards, and there's regular performance monitoring through A&E boards on a monthly basis of the AS performance, especially in relation to response times and handover times, etc. And there are some key performance metrics. In relation to flu, there are detailed plans already in the system around flu and immunisation, and that's just starting to gather pace. And we can get an update from public health colleagues. I'm not sure yet into the monitoring of actual uptakes, but that will due to be started soon, and that comes through Public Health England, and that's then reported on a weekly basis from all aspects of the system, because obviously pharmacists and other areas now are as important in delivering those immunisations, vaccinations, as are GP surgeries themselves. So in relation to sort of, I hate to use the words, the command and the control of the system during the process, that's probably more through, if I can bring colleagues in to respond about how that physically operates on the ground and how we initiate command calls at a sort of bronze, silver and gold level. So there's an understanding of that. Would that help?
Sorry, Ellen. Yeah, I mean, that's fine. I mean, we can come back to all that, but who's in charge?
Ultimately, NHS England. So I'm just going to hand over to John, because he tends to draw together the elements of the system under what we call MAID calls. So it will make sense operationally if John just goes through that.
Okay, so again, I'm John from the CHFT system, so I work across Calderdale and Great Huddersfield. So yes, I agree with what Joan was just saying there, in that yes, NHS England ultimately are in control or in charge, and we follow any kind of diktats or processes that they want us to be able to follow. But that's interpreted both across the CHFT system and the Mid-York system as well. So across the CHFT system, for instance, we then put together our winter plan. Our winter plan is based on all of the additional plans that you received from the likes of Kegley Social Care, from LCD, from Locala and so on, and that's incorporated into our winter plan. We then take elements of that and incorporate it into our surge and escalation plan, which is then shared around partners. So all partners are very clear, again, across the CHFT system, and it's replicated on the Mid-York side, in that when a escalation process that should start. Last year, as something new in our plans, we actually detailed thresholds within our surgical escalation plan. For example, those thresholds can be something like if we have 80 to 89 patients waiting within CHFT, waiting for transfer out of the hospital, so they are on the transfer of care list, and it's been at that figure of 80 to 89 patients on that transfer of care list for 3 days or more, then that is a trigger to guide us to escalate into silver. When we escalate into silver, any kind of escalation is done through the A&E delivery board, which is devolved down to the surgeon escalation plan. So if a threshold has been reached or if an out of ordinary circumstance has been hit, then we would escalate from bronze, which is your normal operating level, into silver, or in some terms in gold if it is an extreme event. By escalating into silver, there are templates included in the surgeon escalation plan, which is then sent round as a call for all partners to get onto a call, what we call our silver command call, which is chaired by a CCG member. It alternates between myself and Calderdale CCG, and we then go through on that call exactly why the call has been called for, which partner has called that call, be it CHFT, be it Kirklees Council, be it LCD, be it YAS, for instance, to say, okay, that partner's then called the reason for that escalation because we have hit one of the thresholds, and now we need to try and support that partner in resolving that issue. Myself as the chair would then go round, confirm what the actual issue is, and then we go around the table to see against partners as to how that issue is affecting them, because it may well be that it's affecting YAS as far as transport, or it may be affecting our community services if it's an issue within CHFT. And then we then go around the table or around the call to say, with partners, what can partners do in order to support the system in order to overcome the escalation that we're through. That escalation stays in silver call status until we then de-escalate again. We de-escalate once that issue has been done. This worked extremely well across the CHFT Calderdale Great Huddersfield system last year. If I take you back 2 years, we went into silver command calls at the end of October, beginning of November, and we stayed in those calls on a daily basis until Easter. It was a very, very difficult winter for the system. We took learning from that and we then incorporated it into our new revised surgeon escalation plan, which is an iteration of what you've got in front of you. And we then took that learning to say, right, okay, well, we need to get on top of this. Last winter, as a system, we felt we were very much on top of it. As an example, we only escalated into silver twice. And one of those was because of a failure of a home care provider. So it did work extremely well. The reason why it worked well was all partners and all stakeholders were very clear as to what the escalation process was, the reasons for that escalation process and how to go about it. So it worked very well last winter. So we've still taken the learning from last winter because there's still learning to come into this winter, and we've incorporated that into the winter plans and the surgeon escalation plans that you've got in front of you. I'd say the biggest change that we've had to our surgeon escalation plan is we did not want a separate surgeon escalation plan in place due to any ramifications due to Brexit. So we've agreed with our EPRR colleagues that instead of having a separate surgeon escalation plan and separate calls and separate processes, if they needed to, they would escalate into the winter calls and the winter surgeon escalation plan in itself. And Sharon, is that more or less the same as working on your side?
From an escalation perspective, I would say we follow a similar procedure. What we've been doing across the Mid-Yorkshire footprint is working together with both community and acute trust partners. And we've actually practiced how we would deal with issues, for example, care home closures, the loss of care home, care packages, issues. Sorry,
if I could stop you there,
yeah.
Please. Fine. I mean, this is what I really wanted to come to. Both Perfect Storm that I quoted and Hidden Crisis
Yes.
Insinuate, and I know that it probably will not happen, they insinuate that Armageddon could be on the cards. And I just wondered what would happen if you got an organisation that was failing.
Yes.
And you've touched on it with say, a care home closure,
Yes.
or a particular part of an organisation, you know, like an A&E department that was just creaking
Yes, yes.
and couldn't cope anymore.
And that's the idea of the emergency preparedness process for winter. So we look at every aspect, not just the acute trust, because we recognise that at most winters we've got demand in there. So scenarios that we've looked at and practiced, got different people around the table for, have been things such as care home closures, reduction in domiciliary care, etc. And this is where I believe that the system is maturing extremely well, because we do come together as an integrated health and social care system.
So if they're a failing organisation,
Yes.
you'd bail it out amongst yourselves?
We would definitely...
Or would you rely on NHS England to throw you the lifeline?
Well, NHS England don't have any other resource than us. So what we would do is we would sit down, we'd follow any emergency planning situation, sit down, discuss what the problem was, work together as a system, identify how we could have the least impact on the people that we serve, and they are the residents, the patients, etc. So wherever we could, we would work together to maintain that care. And if we did have to provide alternative care, then that's what we would work together to do. And I have had reassuring meetings with people, discussions. We're putting together additional plans this winter, because we recognise that not only do we have a winter, we do have other problems in other areas that are escalating, but we've got Brexit on top. So we definitely do have that system approach to working together. We all know each other very well. We all trust each other, and we are all very, very aware of what tools we've got in our tool bag to be able to attempt to match any problem that might come our way.
Thank you. I'll stop there and come back later. You've had enough of me.
Thank you. I've got a couple of questions, observations really on the overview report. As Peter mentions, an awful lot of detail in this package. I think because we are the overview and scrutiny panel, we rely a lot on the quality of the overview. So a couple of things on that. First of all, Peter's already referred to the BMA comments and the CQC comments. There was also a report, which everyone will have seen in the Examiner yesterday, waiting times now are as bad as in the winter. So that's raising a concern as well. That level of concern is not really, as far as I'm concerned, reflected in the overview report. And I think it would be useful to have that perhaps as an introductory comment, just setting the scene, the current climate. The second observation is really around the content of the report. And I feel it would be useful for each agency that's referred to in the report, with perhaps the additional ones that Peter mentioned, and from an overall point of view, to have three things emphasised. The first one is the lessons learned from last year. Now, some of the agencies refer to that, some of them don't in the report, and I think it'd be good to consistently have a reference to lessons learned. Secondly, what's new for the current year, 1920, what's being added because there were some problems last year, which hopefully will sort those problems out. And thirdly, and I appreciate this might be difficult, it would be very useful to have some feedback from patients and service users on their experience of coping with the effects of winter pressures in the previous year. So if that was possible to do, I think that'd be very useful, because you're getting an external perspective then rather than the internal perspective of each of the agencies involved. Thanks.
Thank you for that. Is there any further questions?
I've just got some questions on your frailty approach. One trust is saying that they're going to open extra frailty beds in HRI. The other trust is saying that they're going to admit direct to ward. So how is the consistency of approach across Kirklees? How are GPs engaged so GPs know what is happening in each trust as far as admission, where they send people if they need to be sent? How does the ambulance service know what different approaches are? And is it that you are, even though you're opening extra beds, you are admitting direct to ward, you just haven't said it? And the other thing is, What's happening about mental health winter preparedness?
Good morning, everybody, and apologies for being late. I think a few of you have already met me. I'm Michelle Eardley, the Director of Ops for Medicine at Mid Yorks. I met quite a few of you when you last came and visited us on the Pinderfield site. So I'll pick up on the Mid Yorkshire Acute Trust point of view. So we're already doing direct access to frailty at Dewsbury, as you'll be aware of from last winter, and the plan this year is to roll that out on the Pinderfield site. We do work extremely closely with Yaz colleagues and also with our GP colleagues as well. They are pinnacle in describing and arranging the pathway for the direct admission. So we've already got that protocol in place for Dewsbury, and we start on the Pinderfield site next week, and they've been heavily involved in that. We couldn't progress this work without the support of our colleagues. GPs are fully aware of the telephone number that they need to contact with regards to the acute trust in relation to making a referral in, or they also go through the operating route or direct admission to ED, and we can still pull those patients through. So that's probably an update from a Mid Yorkshire point of view.
Okay, if I can talk about from a CHFT perspective, and you were talking about additional beds being opened up at HRI, that is slightly incorrect in that what actually happened is within the frailty assessment unit, although it talks about beds, there are actually more often to be chairs where people are sat and assessed to see if they can if they need further admittance. Primary care know how to access that service. They call directly into the frailty service. Likewise, YAS know how to access that service. And similarly, if someone is in ED, actually walked into A&E, they're able to redirect directly into that frailty assessment unit. And that's headed up by a very experienced frailty nurse called Rennie Comerford, who is controlling access into those beds, although a lot of them in many cases are actually sit and wait chairs whilst they are having further assessments made before being deemed necessary as to whether to access a service in the community or whether they do need further observation and access into any kind of bed within the CHFT itself.
In terms of mental health services, so we are seeing an increase in our investment in a range of community offers. So in Kirklees in particular, there's been the development of the wellbeing cafes. These are essentially emergency sites where people can go to who don't necessarily need to come to acute mental health or acute hospital services, such as A&E, and it's a diversion opportunity for people who feel that they need some emotional support. And there's been an increase in the activity and hours opened. This has been commissioned directly by Kirklees CCGs. In Calderdale, there is a similar sort of cafe, but it operates on a more limited time basis. And at the moment, ourselves and the Acute Trust, CHFT, are approaching the commissioner there to increase that because we want to see further pressure lifted off people attending A&E department there at Calderdale in Halifax. In terms of other mental health service investments, we've seen some investment this year through the ICS into our intensive home-based treatment, our crisis home treatment services, and that's been across the footprint in all of the trust. And that investment has now come through in terms of increasing the capacity for the intensive home-based treatment 24-hour service to operate across the whole of the trust footprint. In terms of other services that are regularly occurring, we have already a very comprehensive A&E liaison service, mental health liaison service on both sites. We meet all the national standards. In fact, we're slightly above the national standard in terms of commitment to that. We're also seeing an investment into older people's mental health services in the community this year from both CCGs in Kirklees and also in Calderdale. And that means that we can outreach now more intensively to people's care homes, residential places, so that we can avoid people having to come into care in the acute side, but also it means that we've got capacity to support people in the home on an intensive basis that hadn't been in place, say, a couple of years ago. So there has been quite an uplift in the range of capacity and services available for mental health. The other issue that we've had in Swift has been difficulty with having enough adult acute beds available locally. So we've done a significant amount of work this year to try and create the capacity to work with primary care to look at the referrals coming into mental health. And as of, I think of today, we're now 4 weeks where we've not had any patient placed outside of the trust footprint, which is actually quite an achievement, because we still receive an awful lot of referrals from Kirklees and Calderdale GPs, something between 30 and 40% over and above those we'd receive in Barnsley or Wakefield. So there's still a dynamic in this area for referrals, but we're managing with some of the changes in the investment to actually manage the bed base much more effectively.
On the frailty side, what systems do Mid Yorkshire have in place for expanding their frailty should it be needed? Because there were times last year when the frailty unit at Dewsbury was full at times. And what plans have both trusts got in place to remind GPs and what the procedures are? What communications have you got to just put that front and centre for them so that they have it well ahead of the end of October, if that's where the rush is? Okay.
Hi. So I heard the first bit, which is in regards to if capacity becomes a challenge. I'd missed the second part, sorry.
How are you going to update GPs so they're reminded as to what the procedures are?
Yeah, okay,
because they didn't always work last year.
Okay, so if capacity outstrips demand, we will obviously decant patients off onto one of the other wards out at Dewsbury, and we do that successfully and have done for over a year now. What we are also doing is putting in permanent permanent therapy services 7 days a week. So we did that for last winter, but then the investment has been now put in permanently, which will have a massive impact for patients and being able to get patients out quicker. We've also introduced a same-day emergency care frailty unit at Mid Yorkshire as well, and that means that our throughput of patients through the frailty units is much quicker and patients are not staying in for longer length of stays. So it's only been open 3 weeks and we're already seeing a reduction in time spent in the units. There'll be no change in procedures for GPs. They go through the appropriate telephone lines that we've had in place since post-AHR, and we wouldn't change that. They refer directly into either one of the elderly physicians or one of the acute physicians, and that's not changed. Yes, absolutely, yeah.
Can I just come in on the comms issues as far as liaising with primary care? You'll see in the winter plan that was sent through as part of your pack as from the CHFT system, the Calderdale and Great Huddersfield system. On page 18 of that, you'll see that there are two comms plans that are to follow for this winter. They are the old plans that are actually included and embedded in this document electronically for last winter. The comms plans we've received from Kirklees and Calderdale now. So they will be embedded into the updated document on this, and I'll take your point forward because a lot of the comms plan do talk about public-facing comms, both on social media, adverts, getting the word out regarding where to go with whatever ailments that you may have, using pharmacy, using your community services rather than turning up at A&E. So that's the type of thing that will be in those those comms plans. What I will take forward on that is I'll speak to our comms leads to talk about how we are actually going to be getting out those comms message to our primary care colleagues as well, so they are well aware as to what's happening within, specifically with that frailty pathway as well.
Can I just come in on that with regards to Wakefield and North Kirklees, because we do actually have that face-to-face conversations with our GP leads, clinical leads on a daily basis. So any transformation, anything new that comes through Mid-Yorkshire, any discussions, we do have commissioning leads that work with the GPs on a daily basis. If there are any changes to pathways, if there are any messages, then they do have that discussion. And we are aware that GPs are not told what's happening. They are actually involved and included in any decision making regarding pathways.
Are you okay with that? All right, thank you. Leslie, do you want to come in?
Oh yeah, hi. Can I just ask about the wellbeing cafes you just mentioned? Are these a drop-in available to anyone, or are they something that people are prescribed to go to? Is it something that we should, as councillors, let people we know have issues be aware of?
So they're provided by a number of local charities. So they're not provided by social services or by NHS. So they're commissioned to be provided by other agencies. So as far as I'm aware, they will accept referrals or people dropping in as they choose to. So they are widely and can be widely advertised for people to go to and seek emotional support, both within hours and out of hours when they're operating.
So are you aware of where one is in Huddersfield at the moment, for example?
I haven't got the precise details, but I'm sure we could send the details off to you, this committee, for you to have and update you, because the timing has changed in recent weeks with the additional hours over in North Kirklees.
Thank you.
Thank you for that. David, do you want to come in?
Yes, a question on the overview report, page 8, paragraph 157. It's to do with Brexit. Given the number of workers from the EU who are involved in healthcare, social care and residential care, I wonder what contingency planning there is or will be if problems arise in terms of numbers of staff who are available to work in those sectors.
So we've been corresponding a lot with our dom care providers and our residential and nursing home providers to be Brexit ready. We always operate with business continuity plans, so we know what to do in the event of different pressures that will impact on their service delivery. So in readiness for Brexit, we've been sharing information with them around the EU need to register staff. We've done some mapping, so we know that the impact is quite low in this area. I think there's less than 5% of the working population that would be affected by that. So they've all been encouraged and supported by their employers to register. So we try to work very strongly through provider forums and communications to make sure that everybody has thought through what the impact might be on them individually, and we're not aware at this stage of anything that's not been addressed.
I concur, actually, exactly the same from the Mid-Yorkshire footprint. It would be the business continuity plan if there was an issue, and we can't anticipate that Brexit is going to exacerbate anything for us, but we've certainly sat down together to look at what we could do if there was a problem, but it's like any other workforce issue, we are prepared.
So is there a specific contingency if there are insufficient staff, say in residential care, is there a contingency plan as to what then happens to try and fill gaps?
Yes, within all business continuity plans, there's always a contingency if there's a staffing shortage. This year's no different to any other year.
Well, I'm just wondering whether it was different because of Brexit.
No.
So there are impacts that Brexit may have on availability of staff. That was the kind of point behind it.
The business continuity will be exactly the same. We are not anticipating any major issues.
And just for assurance as well, we've also done that organisationally. So we've looked at how many of our workers within each organisation are EU nationals. So the same process is being followed. So for instance, I know in Lacala there's about 9 people affected. So in relation to the business continuity plan, we've got a fairly solid assurance that actually we wouldn't, in the event of EU exit, have a major issue in relation to people returning to the home country, because actually there is only around 9 or 10 people for us.
And is the same level of information available for residential care homes and nursing homes?
Yeah, we've done some work to understand what the impact. We've had regular communications through provider forums, and from time to time we do have issues with staffing in care homes. So we are well practiced on managing those situations. So you know, we'll deal with what comes, but we've thought through scenarios quite carefully.
Thank you. Any further questions?
Yeah, can I just ask you about one of the lessons you say on page 25 you've learned is to do with annual leave, training, non-working days monitored to ensure adequate staff. It's just more a well-being question about your frontline staff, because it's perfectly obvious that you're pretty close to crisis, that you're understaffed. I mean, generally the service is understaffed. There are lots of vacancies. The impact of winter, is there a danger that you're getting to the point where staff might be not allowed to take annual leave or Christmas leave or whatever? And so I'm sort of thinking about what's in place for the well-being of frontline staff, particularly in accident and emergency.
Yeah. Hi again. So with regards to training and education and annual leave, what we try and do from a training point of view is you do as much of that at the first half of the year so that it's not an impact over winter. Same from an appraisal point of view as well. Annual leave is split right across the 12-month period, and we actively encourage staff to be taking annual leave over Christmas and New Year. So some organisations previously I've known have stopped that over that period. We don't, we keep that consistent. There are obviously challenges with regards to sickness, but that's not predominantly over the winter period. That's all year round. With regards to the ED staff specifically, we've put a huge investment of over £1.2 million in across the ED departments this year with additional staff, including putting nurses right at the front door to be streaming patients out and getting them to the direct same-day areas. We've had quite a lot of external support with the ED departments around wellbeing and support as well, which they've found extremely positive. So we are doing a lot of work with them. We've obviously got access to occupational health and all the counselling services that are available there, and we can directly signpost people into that. And then staff who have got specific prescriptive working patterns, we try our absolute best to adhere to that as well to support them.
Thank you. So do you feel that there isn't a problem, particularly with staff feeling that the pressures are just getting too great? You know, this perfect storm, which we all feel we're teetering on the edge of. It's the frontline staff always who are trying to cope with that unexpected, the flu virus that suddenly hits.
I think from right across all organisations, everybody feels challenged, and that's been ongoing for several years, hasn't it, right across frontline staff. I think what we're all trying to display and do is all put in as much contingency and wraparound support, and by doing that then you've got a more robust plan for then when something such as the flu outbreak occurs, you're dealing with it rather than out of a manic last minute moment. So contingency plans are so important from that point of view, but I don't underestimate the value of the human in all of this. It is a challenge for all of us, yeah.
Thank you.
Could I just ask CHFT to make a response to Leslie's question, please?
Yeah, if I can respond on behalf of CHFT, I mean, apologies as well. Both Bev Walker and Helen Barker were due to be attending here, but they've got some internal issues that they've had to escalate into the Gold command system internally following a very poor weekend. So unfortunately, they're unable to attend today. So that's why I'm speaking on their behalf, as well as on behalf of the two CCGs. I can just agree with Mick Yorks regarding the approaches that we take, very similar in CHFT. We are having more focus and more monies put into ED as far as our staffing is concerned. We're having Band 7 triage, advanced nurse practitioners put into those, so we are triaging more professionally and quicker at the front door of A&E. So perhaps it may be a case of people are not actually going into A&E, they're being diverted into alternative services, be that in the community or other services within the hospital, such as the acute assessment units or the frailty units and so on. So we are taking some of the pressures off those frontline ED staff by having this additional triage opportunity at the front door of both A&Es, both in Calderdale and in Huddersfield itself. And then we also do have our employee support programme across our system, but be it in the CCGs or in CHFT as well, where people are able to access personal support if they are feeling those pressures and they do need to talk to people.
Amanda, did you want to speak?
I just wanted to say that we've talked a lot about the pressures in A&E, but it's the whole system that will alleviate that pressure. And so we've got relationships over recent years that have started to really develop that we own that as a whole system. So some of the things about annual leave are we can anticipate the pinch points the day after Boxing Day when people have had their leave is a particular pressure point. We try and clear diaries, we try and make sure staff haven't got meetings in so that they're ready to get in there and work as a whole system to support the staff who are on the front line. So it was just to reassure you that we have the MAID calls so that all the partners are around the table to try and work to alleviate it so that we don't create bottlenecks in another area of the system.
Sorry, is it possible I can just come in just to explain? We've made a couple of references to MAID, and just so that you know what this is, on the Kirklees side of the system, for the CHFT footprint, MAID is a multi-agency disciplinary event, which is a one-off event. However, from a Greater Huddersfield perspective, with CHFT, we've taken the learning from that, and we now have, there used to be twice weekly calls, but now they are once a week, every Monday. Whereby we go through as a team, as a system. So we have Locala, we have CHFT, we have social care colleagues on a call, and we in effect go through everyone on that transfer of care list at that time, at that point of the day, to see how we can as a system move those patients on in a safe and effective manner. So we can go through anything up to 60, 70, 80 patients, which seems a lot of patients to go through in the course of an hour's phone call. And it used to take that long to do those calls when we first started this process about 18 months ago. However, because of the relationships that have been built upon those calls, and because we now, instead of waiting to ask partners, can you help with this, partners now come forward on those calls and say, I can do that, I can get that equipment into that person's home in order to get them supported. I can get a bridging package of care put into that so we can get that person out quicker. I can offer a transitional bed in order to move that patient into a bed until their care home of choice is available. So that is what we mean when we start talking about MAID. We have that on the Greater Huddersfield for Greater Huddersfield patients. There is a similar process for Calderdale patients, and I know with Mid-Yorks they tend to look at one-off events in order to take that those MAID principles forward. Okay.
Thank you. It's just as the new kid on the block, the language is a huge learning curve.
Yeah, I mean, to stay with the same question of language, I mean, just for our ignorance, if you wouldn't mind, gold usually equates with excellence and bronze with not so good. Is this in inversed order? And number one, and secondly, how does it relate to Opel, which we do know is not a German motor car?
if I can come in on that, with effect, we've historically used bronze, silver and gold as escalation processes both within organisations and a system ever since I've been working in the system. So that's the language that we use, so that's how it actually works. The actual levels do refer to the OPAL levels, which are your operating effectiveness levels. So OPAL 1 is your business as usual. OPAL 2, there may be some pinches or pressures in the system. OPAL 3 is when we tend to escalate. If we're in OPAL 3, this is to say if the system is in OPAL 3, that normally, when you look at the thresholds that we're looking at, that normally equates to escalating into silver. So this is when all partners get onto a call and try and resolve that issue. If it's OPAL 4, which we've hardly ever gone into, but if it's OPAL 4, that is a direct escalation into gold. So Gold Command is a face-to-face meeting with operational directors so that they can all get together and start committing resources, money and so on in order to resolve the issue that we may have. So there is a direct correlation between bronze, silver and gold and the OPAL levels.
And what's a black event?
That is the perfect storm. That would be, I would say, more than 2 partners which have hit OPAL 4, and that is a case of we really need to get something sorted, and it may be a case of starting at that point looking at our escalation plan as far as deflecting, so using partners outside of our systems in order to be able to support the system itself. So that would be when we're looking at our colleagues in Bradford, in Leeds and in Wakefield, for instance, from the CHFT point of view.
Sorry, and just to come back what I was asking earlier, it's probably not fair, Helen, to try and interrogate you again on yet something else. I think it was 3rd-degree tears last time. Yeah, and so if somebody could let us know how immunisation of the population. I mean, I know about somewhere in the region of 1 million people are eligible this year. More people are eligible, more children, and so on. And I just wondered how we're doing. But leaving that on the table, just coming back to general practice and access, which has been alluded to. We know the system works on delay, and we delay to ration care. We know that. We have to do it. We don't do it if it's an emergency. So we're trying not to harm anybody, but delays in the system. And coming back to GP access, 15 million self-referrals up to the 31st of August of last year. 15 million people waited over 28 days to see a GP. And I raise access really in relation to triage into general practice. Now, we don't have a lot of performance data on GPs, not in the same way as we do with all our other colleagues in this room. It's just not there. And, nobody's asking you to answer the impossible. But it strikes me that the triage system, to be able to see your GPs, is really often handled by a receptionist, and that sometimes trying to get to see your GP it's easier to get an audience with Pope Francis, according to the evidence. And I just wondered how prepared GPs were, and if we're doing anything about getting the right people into the surgery at the right time. Thank you.
So my colleague, who will be the expert in primary care, is not obviously here. Colleagues may want to come in with some further information. But in both North Kirklees and Greater Huddersfield, we have got extended access now into the evenings and into the weekends, which is providing additional appointments both on an urgent and a planned basis. And we've got additional capacity there to access. That's run on a hub model in Greater Huddersfield and I think 2 centres within North Kirklees. And then there's also the primary care network Enhanced DES, which again is to extend opening hours within each practice into the evening. So there's 2 additional capacity measures that have been put in place in the last year, which is actually closely monitored. So the percentage uptake of those appointments is very closely monitored. And there's also potential developments about what those services will offer going forward. Does anybody want to add anything extra?
Yeah, the only thing I would say is I love data. I sit at my desk and read through data. The 50 million that you quoted, that is based on people that have tried to access their own GP at a time of their own convenience. It's not to say they have not been offered a primary care GP appointment. It may be an extended access appointment at their own surgery without a GP of their choice, or it may have been an extended access appointment at a nearby surgery where they have mutual arrangements, or they may have been offered a GP appointment at their primary care centre. The 28 days is because it may well be that they're wanting to see their own specific GP, which is fine if we are able to support that patient choice, but it's not to say that they have not been offered a GP appointment.
Yeah, and that really brings me back to the point, triage. You know, how are we triaging these people?
If I can add another dimension to that as well, which is work that we're doing across the system, when you mentioned around the right people accessing the GP, and there's something about the communications messages that are out there. There are often people, many people accessing GPs when actually there are alternatives to accessing a GP, for example, your pharmacist, self-care, etc. So we're certainly working on a very comprehensive comms plan this winter, because we know that we're going to have additional winter pressures, but that's something that we're looking to work on all year round.
Can I just add, in terms of mental health, so we do receive an awful lot of referrals from primary care, triaged or non-triaged, depending on which way you look at it. So we're working with Dr. Caroline Taylor. She's a GP lead for mental health in Calderdale, so she's working across the whole footprint, including Kirklees. So we started to initiate a new triage methodology with at least 3 practices, 2 in Kirklees and 1 in Calderdale, to try and see whether they can do a better job of identifying people with high need, and those also people who would be benefiting from going to systems that are not either health or social care provided, such as the Wellbeing Cafe. So that's only just started, so we hope to see some benefits from that in terms of helping individuals land at the right place for their need at the right time, rather than feeling frustration about waiting either to go to a mental health provider or A&E, for instance, in some cases.
Sorry, just a quick question. In terms of care homes, what's the red bag scheme?
Well, I can talk from personal experience here, actually. Yeah, not in this health and care system, but the red bag scheme is literally, it is a red bag, it's like a hold-all, and care homes have been issued with the red bag. So if one of their residents needs an admission to hospital or an attendance at A&E, all the basic things that you would put in that bag go in the bag with the resident. So it can be medications, toiletries, a change of clothes, and a brief update and synopsis of what the person's needs are, wants and wishes, and an up-to-date care plan.
Yes, hi. The question was just about this, and I know it was forced on by the government, this extension of doctor surgeries at weekends, but my question is based on, we are short of doctors, and there are vacancies, and yet their surgeries are often have to keep longer hours. What's being lost there, or how are you managing the provision, given that you've got less staff than you had when you were doing it just Monday to Friday?
So it's not just about GPs, it's about a multidisciplinary team that are using those access and providing those accessible appointments. So it might be advanced nurse practitioners, the practice nurses. There are other colleagues now joining into practice surgeries as part of that MDT. So the person who needs an appointment should get allocated the most appropriate person, and that's how the capacity is being extended. So the hope is that GPs should see the most complex patients as part of that system. So they're using their expertise and knowledge to best effect to the people that need that intervention.
So we're gradually having to educate people to accept that the days of, there is that thing about my doctor, isn't there? And I think, on the doorstep, we do hear a lot about the difficulty of getting to see my doctor. So in a way, it's an education thing about, we are changing. you are going to have to get used to this. It's not that it's a worse service, hopefully, but I think there's a lot of reassurance needed for the public around these changes.
If I can just come in there, I think when you're talking about My Doctor, it's, yes, definitely an education out there with people out in the community. It's a case of, as opposed to be My Doctor, is My Health Service, and that health service is made up of a number of different disciplines. And then also going back to the fact of the pressures on GP practices as far as offering all of these extended access appointments and so on. This is to do with partnership working. It may well be that a group of GP practices have come together within their primary network, maybe, and it's the primary care network that is offering on a rotating basis the actual extended access. So it's not to say that all 7 GP practices within that primary care network are open up until 8 o'clock in the evening and every Saturday and Sunday. It's a case of one of those within that primary care network could be open on a rotating basis to offer those additional appointments up until 8 o'clock at night or on a Saturday and Sunday on behalf of the whole primary care network.
Okay, but the only thing there is you have a problem with sometimes with transport. So I know personally, you know, you can't get into My Doctor, but you get one into the next village 3 miles away. I have a car, you know, but other people, you know, that can also then be an issue.
Can I just ask a quick question with regards to home care? I just want to know if there is a crisis this winter, how is the home care service going to be able to cope? Because I noticed they're putting incentives in there. How are they going to retain this, having enough staff to provide this service? I know that they're uplifting the hourly payments, etc., and they've got a scheme which will encourage pupils in schools and colleges to aspire to work in care, but it doesn't mean to say that those pupils will want to work in the care service or be able to work in that home care sector this year. So how are they going to cope with staffing levels? Thanks.
So we've had the issue of retaining staff in social care for quite some time, and so learning from last winter, we've spent a lot of time with our providers valuing them as being part of this team, whereas in the past I think we've seen them as somebody we give a contract to and then hold them to account on the contract. We've got them round the table this year. We've run 3 innovation labs to listen to them and understand what do we do that impacts on them negatively in terms of how they recruit and retain staff. And so we've come up with a number of things that will help, some of them longer term, like getting people through and valuing that as a career pathway. But some of the immediate things are around retainers with hospitals, an increase in the hourly rate, which is really helping us, I think, to compete with things like the retail market so that they can pass that on to frontline staff and that they're not then in a position where they're moving in order to get more remuneration in a different sector. So they're immediate things that we're advised in collaboration with our providers will help. But there are other initiatives. We help them with recruitment and retention. We have a social media campaign that's managed by the council. It's called Into Care, and that's very successful in helping the provider market to recruit. But we're much more collaborative with them. So there's some quick wins to try and stabilise what we've got and make that attractive. And there's some longer term plans around sustainability.
Sorry, just so is there a current shortage of staff in that sector at the moment?
Yeah, we would definitely want more than we've got at the moment. But what we need to do is halt the reduction. If we look at the trend analysis, the amount of domiciliary care provided has been going down. So we do need to address that as well. So we're trying to stabilise it so that trend halts and then work with the market to improve going forwards.
So if we have a severe winter crisis, then it could place them that sector under immense pressure and strain, I guess, which is worrying.
Yeah, it was just really a follow-up question because, having experience of several friends who've actually gone into care, home care, and it's this payment for travel, which seems to be an enormous issue for people. I mean, I'm not just talking here. I've got friends doing it in rural Wales, where you can be travelling half an hour between, and you're not paid for that. And in the end, your wage works out to. I mean, we certainly pay people more to look after dogs than we do to look after old people. And it is an enormous. I know it's bigger than this book, but I think it's an enormous issue about retaining people is paying for travel.
So we've looked at how we'd pay for travel, because one of the issues is if it depends on the length of your call, how many travel episodes you've got within the hour. And so in collaboration with the providers, we've significantly uplifted the hourly rate so that they can, it is in the contract that they need to pay for travel, but whether the amount was sufficient. So the intention now is that this gets passed on to frontline staff and negates some of those impacts. And so we've lifted the standard rate, but we've significantly uplifted the rural rate as well, so that we really help those providers in rural areas to be resilient and to make sure that they can pass on the full amount to frontline staff.
I mean, I take it's financial, that you can't actually put people under a fixed contract where they're paid hours like from 9 to 5 or whatever the shift is. And that includes travel. You're not paying for your own travel. You are, contracted, and then you claim your travel expenses. I mean, that way you severely improve the conditions for people doing a very valued job.
Yeah, well, it's absolutely, as you say, it's a difficult thing to get the balance between the shifts and how we pay for care. But we've used the UK Home Care Association's methodology to work out an assumption of travel time within each hour that we pay, so that the hourly rate reflects an assumption of travel time. And in uplifting that now, we are much more on a par with the UK Home Care Association's rates.
Thank you. If there's no more further questions, I'd like to thank the officers for the reports that you've put together and for attending this morning. And I'd move on to recommendations, that the panel considers the contents of the report that's been provided before us today, and we implement and monitor the winter plans for 2019 and 2020. Evaluating the impact and share the evaluation across the system and identify any further areas of development. And also the lessons learnt, if we could get some feedback from the service users, and if you could provide us with a list of the wellbeing cafes and community cafes to the panel members. Really appreciate that. Thank you. Sorry? Okay, thank you for that. If we can move on to the next agenda item, which is the work programme for 2019 and 2020, on page 235. Just go through each item.
Chair, or you can just want to flag out if there's any member have any comments about it, we can clarify. That's what we've got coming up in terms of.
This paper has been presented to us before, so if we want to highlight anything from that, if there's anything that you want adding or removing. If not, we'll go on to the plan for the future meetings. For the 12th of November meeting, we have the integrated wellness model and Kirklees Health Watch. Has that been confirmed?
Yeah, all confirmed.
Yeah. That's been confirmed for the next meeting. For the December meeting, we're looking at Locala, and that will be a specific session just on Locala.
Just remind them about, we've circulated the comments.
And then January we've got the suicide prevention and Kirklees safeguarding, adult annual board report. February we've got the sexual health service, and March we've got the immunisation programme. They're confirmed. Richard? Well, anything that you've got to put forward for Locala, any questions that you may have or any comments, if you can pass them on to Richard, so when the officers come, they are prepared.
Yeah, it's just a reminder that that's going to be a workshop, so we'll actually be going out to one of their locations. I'll send out a revised diary appointment. So the comments and questions that I've so far collated, you've all got a hard copy of. So it's just a case if there's any additional comments or any additional questions you want me to include as part of that, because my intention is to send this to Locala in advance of our session so they can start to pull together a workshop that will hopefully will cover the key issues that you've highlighted. And the idea will be at the end of that workshop you'll have hopefully a much better understanding of the organisation, and if there are any themes that emerge, then we can bring it to panel as part of a formal item.
So in the workshop, if issues are raised that we still feel we want more answers to, can we raise them there, or are you saying that might be subsequently?
You can raise them there, but ideally, because Locala seems to come up every meeting, we'd like a specific session so that the officers can respond to us. That's why we're requesting anything that you may have that's niggling you at the moment, if you can forward that to Richard. And he's already given us a hard copy. Yeah. Okay. Okay, thank you for that.
Can we say, Chair, just on a procedural point, if that session, if people could keep their presentations to a minimum and leave us time to ask questions?
We have requested that, both Richard and I have requested. So they are aware of that.
But if it's a workshop...
But ideally, there's going to be more opportunity for the panel members to have that discussion with the officers.
I'm also able to use PowerPoints if they're legible by groups.
You don't forget to use the microphone to speak. Yeah, but...
The venue will be... Richard's going to send out a revised appointment. Yeah. It's going to be somewhere in the community.
It's okay? I think it's the Eddycliff Centre.
Centre, yeah.
Yeah, but I'll send out the details, including the obviously the location of the venue, and it will be an opportunity as well because we're going out to see some of their front line services as well. So it's a combination of actually seeing some of the services that are delivered at the centre, as well as obviously that particular development workshop as well. So we will hopefully give you a flavour and understanding of some of the services they deliver, as well as greater insight into the organisation itself.
Yes, when we discussed the integrated wellness model, there were some issues that came up at the July workshop. Can they be brought forward to be considered at that session?
They've been included in the brief. They have been included.
Great,
in the
thank
brief.
you.
Yeah.
Okay, thank you for that. And thank you for your attendance. The next meeting will be on 12th of November. The meeting is closed. Thank you.